This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thanks very much, John. Today I'm going to be talking about something which I've had really only oversight in, and you need to come to the next two sessions to see the people who have actually done all the hard work. And I just want to acknowledge the support of ANZICS in actually getting this up and running and actually helping us brand and develop this product and getting a national approach to multiple trainers and experts in training techniques. So today I'm going to talk about some important concepts in the rapid response team. A lot of the comments I'm going to talk about in this section reflect exactly what Anne talked about. Ad hoc team assembly, diversity of MET causes, and how METs differ from cardiac arrests. I'm then going to talk about the concept of roles and goals, and then I'm going to talk about an overview of our training program, which is going to be the next two sessions of the day. So there's a number of very important concepts in rapid response team calls. They're called when staff on the wall feel out of their depth, they're unable to get senior or appropriate assistance, and they're concerned about patient safety or clinical issues. So essentially, for the ward staff, it constitutes a crisis. And the RIT members, when they arrive, they're highly unlikely to know the patient. They may not know the ward staff. And in big intensive care units who have a lot of staff, they may not know each other that well. So these are very important concepts about interpersonal interactions within teams. And the formation of the team is ad hoc. There's variable team members, variable team composition and seniority. They're highly unlikely that they would have worked together, extremely unlikely that they would have trained together, and their skill sets may not be known, so you might have quite variable senior, particularly medical or nursing leaders, and the rapport and communication skills may not be familiar. And all of this is articulated fantastically in an article by Stuart Gillen, who was one of our advanced trainees in 2011-2010, and it's in critical care resuscitation. And so this is the composition of rapid response teams in 39 hospitals, and a number of other presenters have talked about this. The variable involvement of senior and junior staff, and the variable involvement of intensive care nurses, site managers, coronary care nurses. So this is putting some facts or semi-quantitation on the concept of the variable team composition. When you look at the causes of rapid response team calls, they are massive in number and diverse in nature. And so this is a publication that we did just from 400 MET calls at the Austin, where we just looked at what the registrar and the nurse thought was wrong with the patient in 2006. And there were clearly some multiple causes within each of the MET calls. But just for hypoxia, for example, there are multiple different causes. So this is a very important distinction between cardiac arrests and rapid response team calls. As Anne alluded to, when you have a cardiac arrest, the starting point is clear. The patient's already deteriorated, and some might say they're already dead. And the classification is relatively simple. They're witnessed, non-witnessed, shockable, non-shockable, and then you look for your reversible factors, the four H's, the H's and the T's. The treatment of cardiac arrest is highly protocolised. You can practice this as a team. There's a limited number of roles, and the team goals are clear. The team goal is to perform artificial ventilation, effective, prompt chest compressions with a rate that's appropriate with minimal interruptions, and shock the patient as quickly as you can when they have a rhythm which is amenable to that. So there's a very limited number of things that you need to do during a cardiac arrest, and then you identify and reverse the causes if they're present. This is just for hypoxia. The details aren't important, but the treatment and the causes for hypoxic MET calls are diverse. The treatment and the causes of hypotensive MET calls are also diverse. So treating an algorithmic approach to every one of these potential differential diagnoses and managements is exceedingly difficult if one focuses on the actual differential diagnosis and the treatment per se. So rapid response team calls are much less discriminated. And this creates a lot of barriers to training the team. There's a diverse number of etiologies, a wide variety of treatment depending on the cause and the etiology, the underlying pathophysiology, the severity of the deterioration, and even the experience and the presence of the staff members that are present. So you may not or may not be able to institute therapies that the patient may or may not need, for example, non-invasive ventilation, insertion of invasive vascular access if staff aren't there that have those skills. And there's a variable expertise of the trainers, and this is quite important in debriefing because people will be variably robust to receiving positive and negative feedback. So it's quite difficult. In the past, we have thought to assess and provide feedback, and I think that perhaps some of the problems is that people are preoccupied with judging the quality of the actual treatment for the individual condition rather than focusing on elements of team interaction. So we have developed and piloted a training course last year in the Gold Coast. It's an iterative process and it's been revised slightly, but not significantly, and it's pitched at clinicians and non-expert teachers, but there are some elements of advanced education in there as well. And it's the first step in working towards a curriculum, as Anne and Leslie have alluded to, for individual clinicians, for working in silos, and I'll talk about that a little bit more, but also what are the elements of team training, particularly in non-cardiac arrest situations. So we've brought into the forum the concept of roles and goals, and this is built on prior publications that Ronaldo and I were involved in. And again, all of these details are important, but we talked about the minimum criteria for managing a Met call. This is way back in 2006. And these are, you could argue, are the goals, and I'll talk about this in much more detail. And then we talked about the individual roles and responsibilities. And the team and the group have evolved this to a much higher degree, and there are individual publications talking about this in literature now. So the goals talk about how well does the team perform as a collective. How well do they achieve or complete several predefined objectives? And you can define these objectives yourself. And I'm going to put up some examples, but you may define them variably according to your healthcare institution, the available resources that you have. And I think this is the beauty of this model of training, is that it's flexible and adaptable. It needs to be ubiquitous and apply to every single rapid response team call, regardless of its etiology, the elements of treatment, and the skill mix and seniority of the team members. And that's something which is relatively challenging to achieve. So this is what we're proposing the goals are. I had a very long list. Cameron Knott came up with the very good concept of breaking it down into the beginning, the middle and the end, and so that's what we've done. So this all sounds very intuitive, but it's something that you can actually teach people to do, and it's also, more importantly, something you can actually assess, and I'll talk a bit more about assessment. At the beginning, the team assembles, they clarify their individual roles, the arriving team gets handover from the ward staff, and the team attends to immediately life-threatening problems. So just in case it's been undercalled, for want of a better word, and it's a true a life-threatening emergency, because the vast majority of rapid response team calls are not that in the immediate phase. In the middle, there is an emphasis on communication escalation and achieving a diagnosis. So the provisional diagnosis needs to be established, and most importantly, you need to give your team permission and empowerment to escalate themselves, because keeping in mind the ward's escalated to them, if they feel out of their depth. And this is what I'm talking about in relation to the variability of the team expertise. If this rapid response team actually becomes a crisis for the team, they need permission to be able to escalate themselves. And there needs to be clear, closed-loop communication with a clear team leader and supportive team followers. And this is all the principles of team training with airway emergencies and every emergency in anaesthesia that has been done in the past. So at the end, they need to document, explain and follow up. Document the call, explain to the patient or surrogates and the ward staff, and make sure, and this is one thing I'm concerned about, that there's a very clear understanding as to who's going to be following up the patient and what the various responsibilities for follow-up are. And as Cameron says, that team disbandment is an active process. People should not just wander off. There needs to be closure of the call. So that's the goals. And then there's also the concept of roles. So this is each of the individual team participants and what they actually do. And the strength of this approach is that you can actually train these specific skills within silos. These tend to be more technically based, but in the case of team leaders, they have also all the non-technical skills and crew resource management type skills. So this is, again, from Stuart Gillen's publication in Critical Care Resuscitation. This shows a patient being monitored and the various team members, up to 8. So you can imagine that there's potential chaos in a rapid response team call when you've got 8 team members assembling. And these details are not important, okay? So you can define them yourself in your hospital depending on the skill set of the staff and who's available, because who's responding may differ. But each person needs to have to understand what their defined roles are. And you can teach these in silos, and when the team come together, there can be an expectation as to who is doing what and what the individual roles and responsibilities are. So this is just an example. This is a published... Leslie's just outlined the curriculum for critical care outreach nurses. Members of our critical care outreach panel at the Austin have published their own training program. They've trained a similar number, about 70 or 80 nurses at the Austin, how to be nurses within a physician-led MET. And this is a summary of the expected skills of our nurses within our physician-led medical emergency team. So there's overlap between those of what Leslie's alluded to, but this is a very concentrated program similar to Leslie's, with mentorship, a log, expected training responses, and the nurses are trained in a silo by nurses. They're mentored by nurses. They have to do a number of supernumerary calls before they're allowed to practice on their own. So, and Judy Curry is going to talk to this in the lunchtime break. Last year in the Gold Coast, we had a brainstorming session, a focus group of multiple MET nurses about what the elements of such a curriculum might be. The physician does all the technical tasks. They need to be empowered again to escalate to their seniors when they're out of their depth. But probably in a physician-led MET, the most important discriminating skill that they need to have that others may have less is the need to do crew resource management and non-technical skills. And so these, again, this is straight out of Stuart Gillen's publication. These are the expected knowledges and technical skills for airway, breathing, circulation, neuromuscular, gastrointestinal, etc., etc. And again, this is just rote learning, and this is what doctors do well. One of stamp collecting, I think one of my tutors called it. But this is the stuff that you have to focus on a lot more, which is not always intuitive. There's some people who do this well. There are some people who do this much less well, and it's something that needs to be taught by experts, in my opinion. I would not attempt to teach this. I think you need to be trained and credentialed in order to teach these skills. You can teach the principles, but not necessarily the detail. So this is just an example, the ANTS taxonomy for non-technical skills in crew or crisis resource management. And again, that's in Stuart Gillen's publication. So how then do you assess it, particularly if you're a non-expert? And this is a form that we've developed. It's a one-page summary. All of this material is available on the DVD we've developed. So this is all on one page. And so there's the team goals up the top, and we're actually proposing that you actually score this, because we're scoring the team, not an individual, and you provide comments. Whereas the individual roles, we're doing a Delta Plus type approach, where we say, what did you do well, and what could you have done better? Or if you did this again next time, what would you have done differently? So the Delta type Plus. And again, it goes through the various expected goals and the individual roles. And we've summarised those succinctly. So these are the 10 goals that we've talked about, and we deliberately try to keep it to 10, or roughly about 10, and these are the individual roles. So in summary, rapid response teams, by their very nature, are very diverse, both in terms of their etiology, pathophysiology, their treatment, but also the team that forms in terms of their skill set and expertise. And we need to take this all into account when we're approaching the way that we teach, train, and even assess the team performance of our teams. Often, these team training skills need to be applied by clinical staff who may not have dedicated credentialing in simulation, like the Harvard course, for example. And so we've attempted to pitch the course at people who have an active interest in teaching rather than expert skills. It needs to be ubiquitous regardless of the nature of the call, and we've emphasised again the roles of the model of goals and roles. With goals, the emphasis is on teamwork, and for want of a better word, some minimal standards in managing a rapid response team call, where the focus is on leadership and followership, and individual roles, where there's a clear understanding of what an individual will do when unfamiliar team members assemble ad hoc, and you can teach this in silos, and the focus on this tends to be more on technical than non-technical skills. Thank you very much.